So before we start, I would also like to introduce my colleagues in Karachi, Dr. Hina.
Yeah,
and we
Hina,
also
Assalamualaikum, Hina. We have met
and
before.
we also have Professor Dr. Iqbal with us. You can see him on the screen.
Assalamualaikum.
How are you, brother?
Bhai. What a pleasure. I did not expect you to be present. Huh?
I mean, how come in your lecture I can be
You are so busy. I thought that you will not be able to present. Thank you. Thank you for
with
coming.
me, very distinguished scientist of the country, Professor Dr. Habib Rahman, very renowned chemist, also the former Vice Chancellor of Azad Jammu Kashmir University and Meerpur University of
Assalamualaikum.
And decorated by several highest medals of the country. So he's here with us also to attend your
I'm
lecture.
so grateful.
Sir, with your permission, should we start?
Geez, sure.
Thank you, sir.
Should I or you?
No, sir. Let me start. Yeah.
Okay.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. I'm Hazima Mozam, and I welcome you all to comstech webinar. We are very pleased and honored and delighted to have Professor Dr. Liaquat Ali with us. Professor Dr. Liaquat Ali is a biomedical scientist, actually a scientist of an international repute. He is the founding Vice Chancellor of Bangladesh University of Health Sciences. He is the Fellow of Bangladesh Academy of Sciences and Islamic Academy of Sciences. The topic of his talk title today is Healthcare in OIC Countries, Challenges and Prospects. Before we request him to begin his lecture, I would request Professor Dr. Muhammad Iqbal Chaudhry, Coordinator General Comstech and Director ICCBS, to kindly introduce and welcome our guest speaker today. Over to you, sir.
Auzubillahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Assalamu alaikum, ladies and gentlemen. Good morning, good afternoon, and good evening, because I can see participants from different regions of OIC. I can see some participants from Azerbaijan, some from African continent, particularly West Africa, and I'm sure there are participants from Malaysia onward. You see, some days are extremely important because you always have such a profound feeling of pride and satisfaction. And today is certainly one of those days where I have the honor of introducing again, because I have introduced him several times in many international conferences, home and abroad. And today I'm going to introduce him in this very prominent webinar series in which we invite the best of best in the OIC region. And Professor Dr. Liaquat Ali is certainly among the best of those best. Professor Dr. Liaquat is not only my dear brother, a very close friend of ours, a research collaborator, a long-standing friendship, and a shared mission of spreading knowledge for the benefit of people. And then we have a profound understanding on many issues of very personal nature, professional nature, political natures, and different kinds. So Professor Liaquat is very close to my heart, and of course, his excellence is beyond doubt, is proven at the international level. He is certainly among the best researchers in the field of health sciences in the Muslim world, being awarded with many awards and honors. And among them, he's a fellow of the Islamic Academy of Sciences. So I have the honor of introducing Professor Dr. Liaquat Ali. He is a biomedical scientist, educationist, and socio-cultural activist. He has a broad range of interests, and he is not only, many of us are just confined to a discipline, but his breadth of understanding is beyond the narrow discipline, where he, of course, has excellence in terms of linking them with the use of societal need. He has worked at the level of community. He has tremendous interest in literature. He has culminated the culture of curiosity, culture of excellence among young people, and I am the eyewitness of some of his contributions. With graduation in medicine and Master of Philosophy in Medical Biochemistry from Dhaka University, which is among the most prestigious institutions of the subcontinent, he proceeded for PhD in Medical Cell Biology from Uppsala University in Sweden. He served various public and private institutions, including IPG-MRI, BADAN, which is Bangladesh Institute of Research in Diabetic and Metabolic Disorder, and the Bangladesh University of Health Sciences, where he served as the founding Vice Chancellor and laid the foundation of this wonderful institution on firm ground and with great commitment, sacrifice, and perseverance. In collaboration with fairly large number of institutions in home and abroad, he has supervised and co-supervised over 300 Master of Science, MPhil, and PhD students, and also MD students in various health and biomedical disciplines who are now working all over the world. About 1/5 of these students are from regional and international countries. So he has a strong impact on the landscape of research in the field of healthcare in the region and beyond. With over 280 research publications in peer-reviewed journals, books, and nearly 150 invited lectures in 39 countries of the world, Professor Ali's contribution is beyond the country and has spread all over the globe. He has worked in etiopathogenesis of diabetic mellitus among Bengali population. He has developed methodology of various different kinds of clinical studies on anti-diabetic plant medicine. He has contributed in research in the field of nutritional evaluation of local food materials, epidemiology of cardio-metabolic diseases, and health system research in general. Along with his academic and scientific contributions, he has always participated actively in health-related initiatives from public as well as in private sector. So I've actually traveling in remotest corner of Bangladesh for serving the communities on ground zero level. So his activism is his draws strength from his sincerity and commitment. He has been serving the Ministry of Health and Family Welfare and its directorate and agencies as an expert member in a number of committees. He is one of the 8 public health advisors, as well as the convener, member of the several committees of government to fight COVID-19 pandemic, very difficult time, which we have all seen. His contribution in education, science, and healthcare, Professor Lee has been awarded with fellowships, memberships, honors from various professional organizations, including Bangladesh Academy of Sciences, Indian Public Health Association, Islamic World Academy of Sciences, and Indian Institution for Study of Asian Traditional Medicine. He has also been a visiting professor at the International Center for Chemical and Biological Sciences in University of Karachi, Pakistan. In addition to this, his contribution in professional field, Professor Ali is also known as a socio-cultural and literary activist in Bangladesh. He is the founding chair of Pothicret Foundation and operates popular intellectual think tank with a large library and discussion room. So I have seen extremely stimulating, thought-provoking, and very in-depth discussions on topics beyond science, philosophy, psychology, and whole range of other topics. He has particular interest in history and philosophy of sciences, and among his writings, in this field, the book Geometry and Philosophy, published by Bangla Academy, is widely acclaimed. I must say that despite the fact that I have read this introduction, his personality is much more than that. With this, I would like to request my dear brother, Professor Dr. Liaquat Ali, for his presentation on a very important topic. Thank you very much.
Assalamu alaikum and good afternoon. First of all, my sincerest gratitude to my dearest brother and one of the greatest role models, not only for me, but I think for the whole Islamic world and in the world in general, Professor M. Iqbal Chaudhry. He's not only my dearest brother, but what he has told about me is an expression of his love towards me. But I think we should really follow Professor Iqbal Chaudhry's footsteps, who he has been contributing not only for science, but for the development of mankind in general, and particularly for OIC countries. And I am very grateful to him and to Comstech for inviting me to this very important series, webinar series. And I hope that Professor M. Iqbal Chaudhry lives for a long, long time and leads us in this very difficult time. So with this compliment and with this gratitude, I'd like to go to my topics, which is healthcare in OIC countries, and I'll touch a little bit of the problems and prospects in this field. In fact, the whole development agenda in the world is now driven by what is called Sustainable Development Goals. Up to 2015, it was MDG, and now everywhere the buzzword is SDG. And when we look at the goal 3, this is good health and well-being. Although all of the Sustainable Development Goals, in fact, have a direct or indirect relation, but goal 3 is specifically designed for good health and well-being. I would like to draw your attention to the term well-being, because until recently, that was not within the community, in the health community, used very much. In fact, the term well-being has been introduced in this SDG, and because the well-being is in addition to physical and mental health, which has been traditionally used, and later on social health, but well-being is much more than. It is also part of the spiritual or your inward wellness, which is very, very important. So, and this is very interesting because our Prophet said, after faith, no one was given anything better than well-being. And the well-being term is now used in the SDG agenda. So this is very interesting that the term well-being is very much within the Islamic culture. And if you look at the OIC vision, this is an official vision of the OIC where this SDG has been aligned. In fact, the OIC health vision says, central role of health in overall human development, socioeconomic progress, and poverty alleviation. And health domain identified as one of the most important areas for joint Islamic action. And in line with the health-related goals of SDG, in fact, the YC health vision has been planned. So in theory, the vision is very much in line with the international agenda, in line with our Islamic vision, as I said, from the saying of the Prophet. But when you look at carefully the real situation, we can see that there are basic challenges to realize the OIC health vision. Although we must acknowledge that the that considerable progress has been made, but most of the OIC countries are really facing difficult challenges to realize the vision. And particularly the developing member states, like in South Asia or Sub-Saharan Africa, and also in war and conflict-affected regions, they are suffering particularly from inadequate healthcare in all terms, like availability, accessibility, affordability, and above all, quality. So in many of them, in fact, people are seriously suffering from various challenges, and those challenges are related to adequate financial resources, infrastructure, workforce, and also appropriate national health policies and regulations. Now, in fact, this has been realized when we look at the OIC Strategic Health Program of Action that was designed for 2014 to 2023, incidentally, for up to this year. And they correctly actually realized, rather than targeting single diseases, I must say that in earlier decades, the tendency in health sector was to address specific diseases like tuberculosis or malaria or other infectious diseases, cholera. But the recent trend is not to address specific diseases, but it is more to have a system approach. That means it is strengthening the basic system and some of the outcomes which we need to address, and then specific diseases, fall into specific system issues where not only one system, but actually multiple system affects the outcome. So correctly, in fact, the OIC Strategic Health Program of Action, in fact, correctly identified certain points, although nowadays some of the things have been expanded after the SDG agenda and universal health coverage, but they correctly identified that we need health system strengthening, we need disease prevention and control, which is very, very important now, and we understand after the post-COVID situation. And then maternal, newborn, and child health and nutrition. They correctly understood that the medicines, vaccines, and medical technology should be improved. Again, we realized during the COVID-19 how important they are to develop, to be developed in each country and in the indigenous way. Because medicines and vaccines are the most costliest components of healthcare now. Then we need emergency health response and intervention, because you never know when one pandemic goes, another pandemic comes, or epidemic, comes all the time, coming back and forth. So we have to get prepared for emergency health response, and also information, research, education, and advocacy. So the identification was quite, comprehensive, and I was amazed to see that this was done already. But honestly, when you look at the implementation of these systems, and even for information, which is the basic problem today, when I try to get information, specific information about OIC, unless I dig into various databases where some of the findings can be accumulated, and not always it is easy to isolate all this data and put it into OIC frame. So information is also lacking. Research, we know, except some of the centers like ICGBS or some of the specific centers which are excellent world level, but many of the centers are not up to that level. So we have to see that all these, unfortunately, in all these areas, the set performance is not satisfactory. Although the vision was there and the program of action has been designed, this is the real situation. We have to acknowledge that. That is the challenge we are facing today. So if we look at some of the, because as I said, when we are talking about health system strengthening, that health system strengthening includes, first of all, financing. How much really the financing situation, really how much is spent from which source. This is very, very important. and really how much percentage of budget is spent, because that gives an indication of how important health is given in the overall development or in the budgeting situation of the country, and what is the situation of the human resources, what are the social determinants of health which are being addressed, and particularly rather than diseases, what are the underlying risk factors, how they are being addressed in our system. So these are areas which I'll just touch, but as I said, it was almost impossible to gather up-to-date data unless we have a long research agenda or study agenda for specifically designed for that by, so to say, data, extraction from various databases and accumulating. But one very important thing was done in 2017 by OIC to have a bulletin, and that was one of the very helpful documents, but it has data from earlier years. But I could see from other databases that the situation has a little bit improved, but the proportion of the relative importance of health almost has remained the same. So if we look a little bit of the earlier database, for example, if we look at the health expenditure per capita, if we look at the left, the OIC is at the lowest. Even from non-OIC developing countries, in average OIC, health expenditure per capita is very, very low. In fact, around 49 or something dollars. And non-OIC, this is developed country, and world average is like this. So if we look at this, it shows that on average, we have very low spending per capita in the health sector. And unless we have a certain amount, because the from this data 202, it is really not much. We cannot really compare with any other country, even on the average in the world. And if you look at the lowest and highest, like Nigeria or Bangladesh has improved little bit in the following years. But if you look at all these countries, Pakistan was always better, but right now this is more or less closer to Bangladesh. But unless you look at the higher level, and this shows the disparity. You see, certain countries are so in such a, this happens when catastrophic health expenditure. Actually, what we mean by that is that a family becomes very much poor after one single episode of major disease, like cancer or cardiac operation. One family goes poor, it's catastrophic health expenditure. So if you look at this very, very poor situation in per capita health expenditure. And when we look at how much really governments really give importance to health, again, when you go to the OIC, you see this is in 2000 and this is 2014. As I showed, this was, for example, 2000 and 2014, there are improvement. As I said, it is improved, but this improvement is not satisfactory. So from 3.9% on an average, only 4.6% of the GDP. Actually, the percentage of GDP is very, very low. If you look at the developed country, this is a very high amount of percentage, and even on the world average, we are not really at par. And when we look at the in other way, with the highest share and lowest share, some of the countries have very high, some of the country almost are very low, and this is something we have to look at. And when we look at the share of the government, this is very important, that how much the government really spends in health. The share is also on an average very poor, and even from the average of the developed world or non-OIC developing countries. But there is a very much high disparity here also. In certain countries, it is very low. In certain countries, it is very high. So average always does not reflect the real situation of most of the countries. This is an important fact. And when we look at the sources of the health financing, this is very important because if we spend much with out of pocket, then it is no longer not helpful to because people are getting poorer with the out of pocket expenditure. And even with poverty, health is so important that they sell property or they sell their livelihood, and somehow they collect the money to this is something they cannot afford. So in fact the overall percentage is here, but the spending out of pocket has grown up with the depending on the country situation. So very high share, 36%, but specific countries spend much more, because here the reverse picture is there. The richer section of the richer countries spend less on out-of-pocket expenditure. So if we look here with the highest share of health financing, some of the countries really out-of-pocket is very, very high. You see, even 72, 67, these are official figures, in fact, taken from official. From Pakistan, for example, 59%, but it has gone up. In fact, right now it has gone up. And the point is, if you spend 100 rupees, for example, and then you spend 70 rupees from your pocket or 60 rupees, government contribution is very, very, social security is extremely low. Private insurance in some countries are there, but they can they can spend on private insurance. In Bangladesh, for example, or otherwise in Pakistan, the private insurance is in Egypt or Yemen or Kazakhstan, private insurance is insignificant. But if we look at, for example, the out-of-pocket means from the family, as I was saying, with this expenditure, many families every year becomes poor, because with this heavy burden of out-of-pocket expenditure. And these are official figures. In many countries, in fact, like in Bangladesh, you have to pay underhand table to get this service, even for government hospital. And this figure goes up because that is not counted in the official figures, right? So, and then the money for spending for physicians and nurses and midwives, this is in the OIC, the health workers per 10,000, not money, sorry, the density. Per 10,000 people, right now, WHO suggests that there should be 44.5 persons on an average health workers, and out of which one should be physician, three should be 3 nurse, and 5 other technical health workers. This does not include the ancillary health workers like cleaners, but technologists and other expert health power. But if you look at these figures, the world average is more or less correct, but we are much below the world average with the physician and nurses. But this is an average. And in some countries, when I'll show the countrywide, some of the countries have very low numbers on an average. The percentage per 10,000 population density is very low. In some countries, in Middle East and other countries, the density is quite high. So this density, in fact, includes ancillary workers. That's why it is so high. But in fact, the expert manpower is not so. But they have certainly more than optimum human resources. Some countries are totally at the lowest end. As I said, apart from financing and health workforce density, the sanitation and water source. And if we look at the OIC, even compared to non-OIC, they are more or less close. This part has improved a little bit in many countries, but there are, of course, disparity. When we look at the infrastructure, number of health facilities per 100,000 population, this is the situation back in 2013. So health posts were like this, and this was for these OIC countries. The figure is like this very low, and non-OIC developing has on an average much better picture with health posts, health centers, and hospitals. So in our part of the world, we are more with the hospital building rather than peripheral village level health posts. That is another feature that in our part of the world, we always want to build big structures, big hospital, big centers, sometimes name them with certain catchy names, politically sometimes motivated, but we are not interested to develop the primary healthcare, the health posts, which is, you see, on an average, many countries have more health posts than compared to OIC, which is we have to look at the primary healthcare is neglected when we spend resources. Now, if we look at the health facilities and per 100,000 population, again, there are a lot of disparities. So here, if we look at this, pyramid, now some of the things have changed, but as I said, in general, on an average, this tendency is prevailing still now. So you see some of the health posts are here, health centers are here, but look, hospital, from the hospital point of view, sometimes we have, although number is very low, but the tendency from the health posts to health hospitals is much more. With hospital base, but 10,000, we are also at the lowest end, in fact, with the, as compared to non-OIC developing countries, and of course, much, much lower, 1/5 of the developed countries. And this is again a picture which shows a very high disparity, within the OIC countries. So what happens? The happening is like that, although if we look at the maternal mortality at the outcome level, the maternal mortality from 1990, definitely, even in OIC countries like non-OIC developed as a whole average in the world, it has, of course, reduced, no doubt. That is what we call improvement. And in some countries, by 2015, some of the Muslim countries reached the Millennium Development Goal, which was 4.5. The goal 4.5 was maternal and neonatal mortality rates. So here in female, both in males, we had quite an improvement, like the whole world had an improvement. And if we look at the highest and lowest adult mortality rate, we had, of course, there are improvement, and some of the countries are very, low. Some of the countries are quite high. Some of the countries are higher. This is not always related to the wealth, because some of the countries may have more obesity, some of the countries may have an NCD. But if you look at this part and this part, you can see that how different is the adult mortality rate. It has more than 300, this is less than 100, this is around 50. So you can see the high disparity again. And the total deaths were causes. I'm not going into the detail of this, but the data are there. And this is due to cardiovascular deaths. And you see, and some of these deaths are due to diabetes. And this shows that the in both males and females, this death is more or less cardiovascular disease and diabetes is increasing. If you look at this, there is a tendency to increase. And this is the life expectancy that is always cited by our leaders, that we have higher life expectancy, so we are having good health. As I said in the beginning, that living longer is not always a symbol of well-being. You can live longer. In fact, paradoxically, patients with diabetes or hypertension may live sometimes longer, but they may not be well. They might be dependent on the younger generation, which may create even a burden on the society. They may live with a paralysis, or they may live with dialysis. So, and that makes families poorer. So this is, of course, an important indicator, but that is not the sole indicator, that life expectancy at birth increasing tendencies there, of course, in all countries. There's a slight, increase among these in these years, but not much dramatic change like the earlier decades. And when you see the maternal mortality rate, for example, or look at the maternal mortality rate, it has fallen. As I said, it has improved tremendously. But when you look at here, and we look at, for example, here, the disparity is very, very clear that we are not at par even with the average. It's a developed country, but not even with the non-OIC developing countries or in the world average. So we are not there. And we are again facing a big disparity. You see how is the lowest and highest MMR. In some countries, it's high as Sierra Leone, very high. Some of the countries in Chad or Nigeria or Somalia, very high. In some of the countries, it is very, very low. So this is an important factor. And this is reflected in under 5 child mortality rate. And this is also reflected here. And maternal and child mortality is a reflection of not only health, but women's, liberation, economic development, social development of the women, education, and many, many social and other determinants, which really is reflected in the maternal mortality and under 5 child mortality, which was, in fact, which were indicators of Millennium Development Goal 4 and 5. And those are very, very important indicators. That is a coordinated development of society reflected in a maternal and child health mortality. And we have improved, but not at par with even with average of the non-OECD developing countries. So here, and why not? Because even other things, if we look at just one indicator, how much is really our antenatal care coverage? And antenatal care coverage is reflected in maternal mortality and infant mortality rate or under 5 mortality rate. If you look at OIC, non-OIC, and developed and world, we have much less. And the NC coverage in OIC countries, just look at the disparity from lowest to higher. This is something which we have to look very carefully. Now, the point is the world is going through another epidemic. We are calling it, in fact, last time when we were calling about COVID, it was not a single pandemic. It was, in fact, a dual pandemic. The pandemic was, at the one time, it was a communicable disease like SARS-CoV-2 infection, but at the same time, the underlying ground was given by non-communicable diseases. Because the diabetic patients or cardiovascular patients, they were hospitalized or dying 4 or 5 times greater than the non-diabetic or non-cardiovascular patients. So NCD was the fertile ground for complications of COVID-19 and death. So mortality was driven by that. So it was right now we have all major diseases in the NCD group which are creating pandemic in the world. And if you look at this, the major ones are cardiovascular disease, diabetes, chronic respiratory disease, and cancer, the 4 major NCDs. And interestingly, all of these NCDs are really rooted in the unhealthy eating habit, unhealthy physical inactivity, non-activity in the physical sense, abuse of alcohol and abuse of tobacco. So these are the common risk factors. These risk factors, if they're addressed properly, the diseases do not develop, or even if they develop, they do not become serious. The complications of those diseases do not develop, which we called a secondary prevention. Not having those diseases are primary prevention. Secondary prevention is not having complication of these diseases. And then finally, those diseases are actually leading to sometimes tertiary, problems. And also, as I said, earlier we said only NCD, but now communicable disease and NCD are creating a complex interaction in the modern world. So now we have to look at what we are doing in terms of tackling this bad, the root problems, because these are underlying risk factors. So underlying common risk factors, that also gives an idea about how we are doing in the healthcare situation. So because this is rising, about 60 to 70% of diseases are NCDs even in our part of the world, even in OIC countries, almost ranging in various part of the world in a little bit different way. But nearly 70% in some countries are really NCDs. So when we analyze the underlying common risk factors related to lifestyle, like unhealthy transition in dietary practice, inadequate physical activity, or harmful habits, in fact, the situation is again alarming in OIC countries. And we'll see that there are a lot of insufficient physical activity, inadequate physical activity, and unhealthy diet, leading to obesity. And obesity is also a pandemic in the whole world. And obesity was one of the reasons for COVID, critical transformation of COVID disease. So, and particularly, this is more, so far we have said that maternal mortality or infection, the nutrition, everything is in the poorer countries. But unfortunately, obesity is much more in high-income countries. I'll just show you the table. And average per capita in alcohol consumption has risen. Although the health education has been given, but it has from 1.9 to 2.1 in 2013, from 2003 to 2013. And also upward trend in tobacco use, which is very, very unfortunate. But this is the situation from 18.3 in 2006 to 19.8% in 2015 in various countries. So if we look at this, then we can see that this is the obesity situation. And in OIC, non-OIC, the OIC is a little bit more, this is a physical activity situation. And non-OIC, OIC, if you look at the physical inactivity, is a very big person. And this is in MENA region, this is very high. And then obesity, if you look at the obesity, this is very, very high. This is less, as I said, it is paradoxical a little bit, but obesity is very, very high. If you look at the consumption, alcohol consumption, rather than reducing in amount, and if you look at the tobacco, as I said, rather than getting reduced over years, it has increased a little bit. We did not expect that it should be static. So with this high obesity, with 42, now it is much more. In fact, this has crossed maybe 50 or 60. So with this level of obesity, you cannot expect any well-being or healthy living in such part of the world. So although in one way these are suffering from nutrition or some of the diseases, but of the lower strata, but the upper strata has been started to suffering with an epidemic of cardiovascular disease, diabetes, and NCD-related epidemics. And as I said, these are also related to bad habits. So far, I have gone through some of the underlying causes, some of the system problems, and in fact, I don't think those are very encouraging talks, information. And when we looked at the literature, these are off-track development, I should say. These are not good development. Off-track development is not related to always insufficient resources. In fact, sometimes with even resources, they do not work. But due to wrongly adopted health systems, sometimes the external Western partners or other partners or market dynamics, the companies, they advise or they sometimes, for example, some of the insurance systems are driven aggressively by certain companies. This development is not always due to insufficient resources. So in fact, there was a study in which used a bootstrapped data development system and truncated regression approach. And in OIC, they found that the cost efficiency is only 0.52, technical efficiency 0.72, and allocative efficiency 0.70. So in fact, the authors concluded that in OIC countries, we are not good at selecting cost-efficient input mix. The systems itself are not correctly designed, even within that limited resources. We really always blame resources, but our system is not well designed. So with this efficiency, analysis, and the table was like this, but I'm not going to details because they have put a countrywide efficiency with allocative, technical, and cost efficiency. But I can give you the reference if you like, but I'm not going into the details. So far, I have to say that the information was not very encouraging. Rather, it was sometimes discouraging. But the OIC, I should not say they were sitting idle. As I said in the vision was very much in line with the SDG and latest trends in health reform. And if we look at the declared aims of the OIC health policy, these are the declared aims, and which is eliminate disease and ensure best health for the people in the OIC member states, enabling them to pursue their well-being and achieve their socio-economic development objectives, promote equitable access to essential healthcare, and improvements in social determinants of health. This equitable access to healthcare is very essential because universal health coverage and try to ensure that nobody will be deprived of good health, quality health due to accessibility or lack of resources. And equitable access to essential healthcare is very important. So OIC had it. Work for the development of robust public health systems capable of supporting world-class health standards in the OIC member states. So in theory, these are very much in line with the modern trends that public health should be given importance rather than secondary and tertiary care. Primary health care is the real way to advance health system. And also engage religious and cultural leaders for advocacy and assistance in the health-related activities. So these were the declared aims of OIC health policy. And in fact, a 10-year program of action was taken because OIC actually required it recognized health as a high priority sector with its transformation from a medical issue as perceived by many member states. Many member states think that this is the issue of the doctors and nurses, not the public, not the community. So I think that health needs to be transformed from a medical issue to a development issue. In fact, the COVID-19 pandemic has shown that if you stop health, you stop all development. And some of the groundworks had already been done by OIC. If we look at the really activities, the OIC 10-year program of action, it was TAIPUA, adopted by the third extraordinary Islamic summit. It was held in Makkah in 2005, and where special emphasis on mother and child healthcare and fighting diseases and pandemics it was given. So what are the TAIPUA recommendations? It mandated the Islamic Development Bank, IDB, to coordinate with the OIC General Secretariat in order to make the necessary contacts with the World Health Organization and other relevant institutions to draw up a program for combating diseases and epidemics to be financed through the special fund that will be created within the IDB. So very nice initiative was taken already in 2005. And also strengthen laws aimed to preserving the rights of children, enjoying the highest possible health levels, taking effective measures in order to eradicate poliomyelitis, which was very prevalent at the time, and protect them from all forms of violence and exploitation. So this is the TAIPUA recommendations. And in line with that, in fact, in 2019, IDB, in fact, designed this framework. This framework also is very much in line with the SDG. Affordable quality health services for human development, that was the motto. And the health policy was articulated on 6 pillars, which promotes the SDG 3, as I said in the beginning, and that related targets and contributing to its realization. So this was in line with the SDG 3, because already SDG 3 was declared by that time. And all the pillars directly support the OIC strategic health program of action 2014-2023, which I told earlier, and also there were certain follow-up actions, P5P and 10 years, YS. So if you look at the pillars, that was the, the 6 pillars: target the vulnerable and poor populations. That was very much important. And prioritize the strengthening of primary care delivery and prevention, which is really, even after the COVID-19 in Geneva, there was a reform, framework discussion and review what happened in the world. And the framework acknowledged that countries with primary healthcare, strong primary healthcare faced better. Even within a country, the regions which were stronger in primary healthcare, they faced better. Even the Western world or United States with so much wealth, so much technology, they could not face, because in some cases their primary healthcare was not very good. So this was another priority, and which was recognized before even pandemic. I was very much, amazed to see that this foresight was there already. And if you look at support the national health financing initiatives, so to advance the universal health coverage, as I said, universal health coverage, achieving it by 2030 is a basic to achieve the SDG 3. And in fact, to achieve health for all population, it is health in all policies. This type of impact investment actually, so that we develop policy, health-oriented policy in every sector, and all these other factors for health projects and programs, so that innovative financing mechanism and improve the ISTV governance, Islamic Development Bank governance, and capacity building for health. So all these pillars are nearly targeted to achieve the SDG 3 and universal coverage. So this is, I think we are coming almost to the end. So the general principle of Islamic development health policy is equity, leave no one behind, partnership and improved collaboration, research and development, sustainable solutions, regional and country differentiation. And subsequent steps were taken. In fact, in alignment, actually, the COVID-19 helped. WHO and Islamic Development Bank signed joint agreement on 21 November 2022, promoting strategic collaboration to help their member states. And subsequently, in fact, in many meetings, these were adopted decisions for preventing and combating diseases, improving mother and child health, achieving self-reliance and establishing health implementation unit, strengthening health cooperation, and promoting health equity in the Islamic Ummah. So some of the work, some of the basics have already been done. And in fact, the characteristics of health system resilience has been defined. And if we look at these characteristics, and if we combine this, some of the countries were grade 3 countries, which needs immediate intervention, grade 2 countries, countries of concern. So in OIC countries and non-OIC countries, WHO has defined the health concerns, crisis, and emergencies. So another aspect I would like to just mention before ending, that the concept of One Health, that health is not only a human issue, it is a climate change is a major issue, because climate change has a direct impact on health. Animal health is a basic issue. So it is the concept of One Health which has to be promoted in OIC countries. And because this is also in our religious tradition, in indigenous tradition, it is deeply embedded, the ecosystem, the human ecosystem, and the planetary health paradigm. And this is a key value in Al-Quran also, because with the word earth mentioned 485 times, Al-Quran teaches that the attainment of harmony between humanity and ecosystems is an integral component of one's faith in Allah. And Islam actually emphasizes on the importance of humans as stewards of the planet, with an ethical and moral obligation to preserve and restore the environment. So instead of profit maximization and natural resource exploitation, the laws, Islamic law advocates for small-scale and people-centered development that meets essential needs and diminishes humanity's ecological footprint. So in conclusion, ladies and gentlemen, I'd like to emphasize on the spiritual dimensions of health. As I said, well-being means not only physical and mental health, it has something more than that. And the OIC can be a major partner of WHO because WHO is now realizing this aspect. The OIC can be a major partner of WHO in realizing the organization's evolving relationship with health-related personal beliefs, faith-based organizations, religious leaders, and religious communities. That means the religious actors. The WHO is recognized increasingly this part, and this will be immensely useful in achieving the increasing emphasis of WHO on the spiritual dimension of health, which is fully in line with the teaching of Islam for the overall well-being of human being and nature. So with this, I'd like to thank you again, and thanks to Comstech and my dear brother, Professor Iqbal Chaudhry, for inviting me again, and thank you all for your kind listening. Thank you very much.
Thank you very much, sir. It was an excellent presentation, and you can see that many of our participants have posted their comments for you. So with your permission, should we move on to the question answers for you,
sure.
sir?
Yes,
Thank
sure.
you. Sir, the
Should
first
I?
question
Yeah,
that,
can you feel free? Yeah, please. Please go on.
that we have for you is that as it is from Mr. Suleiman Khan, he's saying that as we always compare things with standards, and every time we found that our countries lack awareness, facilitation, and sanitation, and many other things. He's asking, is there something extraordinary in our healthcare system which is important and unique as compared to other standards?
No, thank you. I think this is a very important issue, and we should, capitalize that. During COVID-19, we realized that because, as I said, that first of all, the ethical aspect in the Western system or your conventional system, the ethics is always the demand-based. That means law demands to do this or do that. But this is a duty-based ethics where we feel from inner side that we have certain duties to others. So if we look during that period, even that crisis period, in particularly, for example, in our country, we saw that although there were certain families where the fathers or our seniors were not looked after by their family members, but in most of the families, they did not leave each other. They were, so in our families, still the youngers, in fact, take care of the elders, and in fact, not always nurses are called. In fact, a large volume of healthcare is given by our family members, relatives, and this kind of cohesion in families, cohesion in the community, and the neighbors. This is a very good capital which we should use in our part of the world. This is very special in our culture, in our religion, which gives a duty-based ethics and which we should capitalize. That is a unique, thing, which also helped us during the crisis period. Thank you.
Thank you very much, sir. So here is another question from Dr. Asma Ahmed. She's asking, among the OIC member countries, what are the alarming and the life-threatening challenges, particularly for Pakistan, with respect to healthcare system?
Yeah, there's a dual burden, and Pakistan included in, if you look at the overall OIC countries, the burden is a little bit dual, and it is bipolar. If you look at the developed Middle Eastern countries where the money is very high, the rich countries, they have a very high percentage of obesity and sometimes lifestyle problems, which has created an immense load on the cardiovascular diseases, non-communicable diseases, diabetes, cancer, and other problems related to obesity, overweight, and overconsumption. On the other hand, some of the poorer countries and the sub-Saharan Africa, OIC countries, they are suffering from undernutrition, infection, communicable diseases. So this burden is dual in a overall OIC countries. But in countries like Pakistan, Bangladesh, the middle, lower middle income countries or mid-level countries, and they are also facing dual burden. One sector of the population, because the inequity has grown so high in this part of the world, in our part of the world, some of the 5%, 10% of the people are consuming so much and having so much wealth. Others are getting deprived. So that is happening in the health system also. And we are not getting the government share. As I said, out-of-pocket expenditure is very high. So with this 70% on an average out-of-pocket expenditure, the poorer families are getting poorer and poorer day by day with one catastrophic event. And so in Pakistan, for example, we have dual burden, undernutrition, overnutrition. So non-communicable diseases, communicable diseases, diseases related to very high obesity, high weight, urban, rural. There is a dichotomy also. And so these are the problems which we need to really address to have a just and equitable society, and particularly in health. Thank you.
Thank you very much, sir. Sir, due to lack of time, I'm just going to take two last questions. So the second last question is from Mr. Farmanullah. He's asking, are the OIC member countries prepared for any future pandemics? I think this is something that is really very relevant in the recent days.
I already shown that in theory, OIC has taken that kind of resolution. In theory, Islamic Development Bank has created its pillars, which are very much in line with the future preparation. But in practice, I think we need to realize, and people like our, Professor Iqbal Chaudhry and others need to lead in OIC certain movements regarding health, prioritization health in their policies, so that these resolutions and these ideals are really materialized. So that is what my response to it. In theory, it is there, the resolutions are there. Okay.
Right, sir. Sir, just the last question. As you spoke about One Health concept, so there is another question from Mr. Farmanullah. He's asking that what steps must be taken, with regard to the One Health concept in the OIC member countries.
Oh yeah, this is a very important question. Now we have to realize that health is not a Ministry of Health issue only. The health is a multi-sectoral issue. And unless we coordinate with other environment, agriculture, industry, many other sectors, and health in all policies, health in every policy, that is a fundamental issue. And that is a problem in our part of the world, including in Pakistan, in Bangladesh, or any other part. The problem is that we work as islands, and the ministries work in islands, and during COVID-19, you have realized that sometimes one ministry announces one thing, sometimes the orders are coming from another sector, which you don't know, the health ministry is not stewarding. So all these things have to be really coordinated, multi-sectoral involvement, and that is the main problem of One Health. And unless we tackle it with One Health concept, we are not going to get rid of the future challenges. That is a very important issue for multi-sectoral coordination, and maybe some like education, National Education Commission, Higher Education Commission. You may need a commission equivalent to Higher Education Commission, a health commission, to coordinate all the activities of the different ministries. That can be one way. Thank you.
Thank you very much, sir. Sir, in the end, I, on behalf of Comstech, Professor Dr. Muhammad Iqbal Chaudhry, and myself, would like to thank you for your valuable time and an excellent presentation. I would also like to thank our participants who joined us from different corners of the world. It was a very informative and a very comprehensive presentation indeed. And with this, sir, we would like to see you sometime in Pakistan as well. And with this, we come to end of our webinar. Thank you very much for joining.
Thank you very much
to all of us.
Thank you very much.
Thank you.
Sir, we have
Sir,
we have Professor Dr. Iqbal with us.
please.
I would request him for the closing.
Thank you.
Every sentence of my dear brother, Professor Dr. Liaquat Ali, has actually opened several questions. And I don't really think that this presentation it is concluding anything. In fact, this is what we request Professor Liaquat Ali to kindly conduct an OIC-wide seminar in which we invite other experts as well, driven largely by him through his leadership, we need to have a broader understanding of these very critical issues of strengths and weaknesses in the entire system and our preparedness for this huge disease burden and the one which we expect in future. So, Hazima, I would request you to kindly formally invite Professor Dr. Liaquat Ali for the health program of comstech as we work, as we are working in Africa and other countries. I think there is a need of a broader strategic planning other than these activities, because everything has to be in the larger framework of what we wish to achieve at the YC level, and certainly in absolutely inspirational lecture. Thank you very much, Brother Liaquat Ali.
Thank you, Iqbal Bhai. This was a great opportunity for me, and I'll be more than pleased to be with you in this venture. Thank you.
Thank you very much. Jazakallah khair.
Thank you very much, sir. Thank you very much, Professor Liaquat, and thank you to our participants for joining. And with this, goodbye and see you next time, inshallah.
Thank you.